Hello friends, in this video we are going to talk about mechanism of labor. I want you people to listen very carefully because this is the one thing that if you understand this thing completely, you don't need to remember this thing every time or mug up things every time. Mechanism of labor is such a thing that you need to understand. It's clearly physical, mechanical. There is nothing to be at the level of molecular level in this mechanism. It's just clearly as mechanical as you can imagine. There is no any doubt that it needs to understand a rocket science. It's very easy. Okay, so I want you to have a very good attention here. Now we have three windows here. In this right window here where I am making star, this window, the theoretical aspect has been given. Here in the left side, lower side, I have shown a video for animation and one another window for some another work. Now what I want you to give your attention. Let's start. Wait, mechanism of labor is what you want from a labor. You need a baby which is inside the uterus. You want that baby to come out from the vagina and into the outer world. Okay, what you actually need is you need that the baby which is inside the uterus should enter the pelvis and come out from vagina. I want you to give attention in this video. See, this is the baby inside the uterus. You can see here. Now what I want here, that the baby should go inside the pelvis. See, the baby goes inside the pelvis. You see here, the baby goes inside the pelvis and then rotate and then come out from the pelvis. See, the baby is coming out. Okay? So what you need is make the very clear thing about yourself. What you want that the baby which is inside the uterus enters the pelvis like here, see, like here, and comes out from the vagina. Okay, so baby has to pass through the parts of the pelvis. Which parts of the pelvis baby had to pass? Everybody knows that the parts of the fetus, female pelvis is like that here. If you see, this is the pelvic inlet and this is the pelvic outlet. Okay, so now this is how pelvis works. This is what you are seeing here is a pelvis. Now let's start from the definition. The mechanism of labor is defined as a manner of the fetal body and head that makes adjustment during passing through the pelvis. This manner is a mechanism of labor. We need to understand how, in which manner the fetus is able to pass through the pelvis, which is actually a miracle thing. First thing in the mechanism of labor is engagement. Now, what is engagement? You can see here, this one is the pelvic inlet and this ball looking structure is a head. First of all, Engagement means when the greatest transverse diameter of the presenting part, that means head in this case, passes through the pelvic inlet. What is the greatest diameter of head? Transverse diameter. Anterior posterior diameter can be changed according to how the fetal head is flexed or deflexed, but transverse diameter of the fetal head, it is fixed. And this part crosses the pelvic inlet, that makes the engagement work. What is engagement? Again, I am telling in this video, I am going to telling two times everything, that the what is engagement? When the greatest transverse diameter of the head passes through the pelvic inlet, that is called engagement. And what is the transverse diameter of the fetal head? Biparietal diameter. You need to see two figures here. I will show you. Okay, now see this. Are you seeing in this video? The head goes inside the fetal pelvis. This is the inlet. Okay, and this baby goes inside the pelvis. This is the transverse diameter of the fetal head that crosses the pelvis. If you see same picture from the lateral side, I have shown you here. See, if you see, this is the spine. We are seeing lateral side. This is the pubic symphysis. This is the imaginary yellow line that is called inlet. The transverse diameter, biparietal diameter of the fetal head crosses the inlet, that makes the engagement. Okay, I am very sure now that you will understand this thing. Now let's go ahead. Now one important aspect you need to understand is station. What is station? When we talk about that 0 station, +1 station, -2 station, what is actually the station? What we do here is we take the lowermost leading part of the fetal head that going inside the pelvis. If you see here in this video here, this is the part of fetal head that is farthermost leading into the fetal pelvis. We want the position of this leading part relative to the ischial spine. Okay, when we talk about station, what we do, we compare the positions of the leading part of head to the ischial spine. Whenever position of the lowermost part of the body in relation to the ischial spine, that is definition. Now whenever this leading part, you see here it is the leading part, whenever the leading part reaches at the level of ischial spine, we call it 0 station. This is ischial spine, the leading part has reached here, and that's why we have called it as a 0 station. The station above the ischial spines are called in minuses, like -1, -2, -3, and the stations beyond the ischial spine, niche, lower, that are called, they are called into +1, +2, +3. Okay, so if the leading part has reached to the ischial spine, that means the station of the fetal head is zero station. If the leading part has not reached yet to the spine, but it is somehow 1 centimeter above the spine, then it is called -1 station. If it is 2 centimeter above the spine, we call it as a -2 station. If the leading part is 3 centimeter above the ischial spine, we call it as a -3 station. Similarly, when the leading part crosses the ischial spine and goes beyond the ischial spine, 1 centimeter beyond the ischial spine, we called it as a station +1. 2 centimeter beyond the ischial spine, +2 station. 3 centimeter beyond the ischial spine, +3 station. That's why we have -5 station and similarly up to +5 station below the ischial spine. Okay, so this was the station. Whenever engagement happens, engagement means, again I am telling you, the transverse diameter of the fetal head crosses the pelvic inlet. At that time, if you see, the leading part of the fetal head has already reached to the ischial spine. So that means whenever the engagement happens, the fetal head is already as almost zero station. Now I want to know the importance of engagement. Whenever engagement happens, that clearly mentions that the head has crossed the inlet. That means there is no cephalopelvic disproportion at the level of inlet. The head has crossed of pelvic brim, pelvic inlet. Okay, you see here, this is the ball, and the ball has crossed here. Okay, so the engagement happened, means there is no CPD at the level of inlet, but yes, there can be a CPD at the level of outlet, but at inlet it is not there. Now when this engagement happens, in nullipara it happens very early, before labor at 38 weeks. In multipara it happens at the start of the labor, because multiparous pelvis is very adjusting to the normal labor delivery, so they don't take load. Whenever the delivery is there, it's okay, fine, engagement happens immediately, no load. Now, what can be the reasons of non-engagement? It can be malpresentation, for example, breech presentation, transverse lie, occipito-posterior presentation. There is cephalopelvic disproportion, either the fetal head is bigger size than pelvis inlet. Okay, so you understand all these things. Tumors in the head, if the rectum and bladder are very full. Also, when the engagement is not happening, what we advise to the patient is that they should frequently empty their bladder and empty their rectum also. That increases the chances of engagement, and very easily engagement happens if they continue to do this thing. Okay. Now a very important aspect that the student doesn't understand actually really is syncretism. Whenever the students hear the name syncretism, they are just confused. They just don't know how to how to imagine the syncretism. This is a very grave situation. I want you attend this lecture very clearly. What is syncretism? Whenever, for example, this is the pelvic inlet, you are seeing here. Okay, now I am putting a ball, that is fetal head, above the pelvic inlet. Now the pelvic inlet and the head, they are almost of similar size. The head cannot easily go inside the inlet. Okay, so what it will do there, the head is where the head is at pelvic inlet. It cannot go easily inside. Why? Because the size of the head is not that small depending on the pelvis. So it doesn't go easily into the pelvis. So what happens? The head tilts there. The head tilts there. Either the head tilts to anterior or either the head tilts to posterior. This is anterior, this is posterior. Okay, so I need to understand you how the head tilts. That makes the synclitism. Now why we are even talking about this term synclitism? Because with this synclitism we can actually clinically get idea of the size of the fetal head, and we get a basic idea of CPD also. That's why it is important. Now imagine if we are seeing the fetal head from the vagina, from below. I want you to imagine that you are seeing the fetal head coming towards you in the vagina. So you are seeing the fetal head from vagina. Just see this figure here. This black circle is what? It is a pelvic inlet, and you are seeing the fetal head coming out, coming towards you. There you can see the sutures of the fetal head. These are the coronal sutures and these are the sagittal suture. This is sagittal suture. These are rhomboid sutures. You identify the sutures? Okay. Now, if the head is not very small, uh, relating to the fetal pelvis, what it will do? The head will tilt either anteriorly or either posteriorly. If the head tilts anteriorly, then you are seeing the two parietal bones here. This parietal bone is called anterior parietal bone. This is parietal bone called posterior parietal bone of the fetal skull. Whenever the head tilts anteriorly, what you see is most part you see is of anterior parietal bone. You see lesser part of posterior parietal bone, and the sagittal suture is tilted toward the posterior border. That is, what is posterior border of the pelvic inlet? It is symphysis pubis. Sorry, oh my god, sorry. The posterior border of the pelvic inlet is what? Sacral promontory. So what happening here is, you need to understand very easily that if the head is tilted towards the anterior, then you will see that the anterior parietal bone will occupy the presenting part more, and the sagittal suture is legged towards the posterior border of the pelvic inlet, towards the sacral promontory. So this asynclitism is called anterior asynclitism. Normally what happens? Synclitism, where both anterior and posterior parietal bone are seen equally. The sagittal suture is in center. It is not toward either anterior either posterior. Okay. In again a second one is when the head is tilted posteriorly. That means what happens? The sagittal suture goes towards anteriorly, and you see most part is made of posterior sagittal, posterior parietal bone, and anterior parietal bone is not seen very well on the presenting part. So this becomes a posterior asynclitism. Okay, synclitism means there is no tilt of head, but asynclitism means there is tilt of head either anteriorly or either posteriorly. That makes the anterior and posterior asynclitism. There is nothing to mug up. Now, let's go ahead. Two things, that is flexion and descent. It happens continuously in the labor. Descent is happening all the time. Flexion of the head is happening all the time. Remember one thing, if the fetus had to pass from the pelvis, it had to bow down its head, like flexed head. Okay? You remember one thing, if the baby has to come out, it has to go down first. It has to get his head flexed. That and then only it can easily come out from the pelvis without any trauma. If it doesn't bow and if it extends her head, that means the delivery will be not that easy and it can get some trauma. So the fetus is learning his life lesson from the delivery only. Jokes apart. Now let's go towards the this thing, internal rotation. When I was a student, I had one question in my mind. Why even this internal rotation happens? What is the need of internal rotation? Why doesn't the baby come out swiftly? Why it has to rotate? I don't know. And that was a very much confusion, that 2/8 of the circle, 90 degree of the circle. I was just confused. So I want you not to confuse. Why fetus had to rotate 90 degree to come out from the pelvis? The reason is here. The pelvis is like this. If we see about inlet, the greatest diameter of inlet is what? Transverse diameter. And if we see about outlet, the greatest diameter of outlet is of anterior posterior. You got my point? Now when the fetal head passes through the pelvis, it passes from its greatest diameter, according to its greatest diameter. So when the fetal head enters into the pelvis, it enters with the greatest diameter available at that point of inlet. And what is the greatest diameter at the point of inlet? That is transverse diameter. That's why the head enters transversely, just like seen in this video. See, transversely, see transversely, see here. Now when it reaches to the ischial spine, the fetus realizes that if it has to come out from the outlet, then he knows it, that the greatest diameter of outlet of the pelvis is epi diameter and not the transverse. So it has no option other than rotating itself to 90 degree and come to the anterior posterior diameter. It was into transverse diameter, but it had to rotate to come in the epi diameter, because of epi diameter is the greatest diameter of outlet, and only that with rotating only it can cross the pelvis. So what happens? The fetal head rotates. See, you see in this video. See, here. It was entering into transverse, then it rotates 90 degree. Okay, now you got the idea. Where the rotation happened? Rotation happened at the ischial spine level, zero station. Okay, now whenever the fetal head rotates 90 degree, the shoulders also tries to rotate 90 degree, but it cannot rotate at that time. So it can only rotate 45 degrees towards the head rotation. Okay. Now the thing you need to understand is in the neck twist between head and the anterior and the shoulders are 45. You need to remember the figures. Anterior internal rotation is what, 90 degree, but the shoulder rotates only 45. That's why the neck twist is of 45. You remember? Okay. Now what happening is crowning. Crowning is what? When the fetal head passes through the anterior posterior diameter of the outlet, which is the greatest diameter of outlet, and it stretches the vulva. It comes into the vagina, it stretches the vulva. That is called crowning. See here. See, this is how crowning happens. See, the fetal head actually stretches the vulva. See, this is how crowning happens. Okay. Episiotomy is given at the time of crowning if it is needed only. Then only. Okay. Now, delivery of the head. After crowning, what happens? Delivery of the head happens by extension. Now, my friends, the world is very selfish. Starting from the fetal life. When the fetus had to come out, it bows down and goes into the flexion mode. When it comes out, the head comes out of the womb of the vagina. Immediately, it becomes very selfish. It does extension of the head. That means he doesn't bow now. Okay, see here. Extension. Hey man, what happened? Hey, hey, hey. See? Hey, what happened? I was just pretending to be bowing, but I am not. Now I am going to make you cry, mother. Okay, see. So the delivery of the head happens by extension. Okay, now let's go ahead. When the head comes out, you remember that it has a neck twist of 45 already, with the shoulder. So immediately what happens, that the neck twist is relieved by rotating 45 into opposite direction of the internal rotation. That is called restitution. Restitution is what? It's nothing. It happens in the opposite direction of internal rotation and of 45 degrees. That what does makes it? Relieves the neck twist. Now head is out. Now the time of coming out is of shoulders. So the shoulders come into the anterior posterior diameter of the pelvic outlet. That's why again 45 degree of external rotation will happen. Why we call it external rotation? Because the before head was doing rotation inside the pelvic. That's why we call it internal rotation. Now the head is again going opposite to the internal rotation, but the head is already external to the vulva. That's why we call it external rotation. The head rotates externally against the internal rotation 45. So internal rotation is of 90 degree and restitution and external rotation are of 45. Both are opposite to the internal rotation. So what happens? The fetus comes out as it was inside the uterus in transverse position. So the fetus is very selfish. When it has to pass through the pelvis, it changes its position, and when it comes out, it is same. It was same. Okay, so this is how you remember these things. Once the delivery of anterior shoulder happens, see here, see, this is external rotation, this is crowning and delivery by extension, this is restitution, see, this is this is restitution, this is restitution, this is now external rotation, see, this is restitution, this up to this, and this one is external rotation. And now the delivery of anterior shoulder happens, followed by posterior shoulder, and with the lateral flexion baby is taken out. This is how the mechanism of labor happens. I want you to remember this thing very clearly, that you need to see this video at least 5 times to get this thing into your mind, and once it's in your mind, nobody can take it out, and you actually get a very advantage of that. Thank you, my friends.